right, hello everyone. Welcome to our Autism 203 lecture for Mood and Anxiety in Autism. I am Rachel Earle, a clinical psychologist at the Autism Center, and I have Stephanie Pickering here with me today, also a clinical psychologist at the Autism Center. And both of us are involved in the Mood and Anxiety program at the Autism Center, and we are really excited to be talking with you tonight. We understand that these are really extraordinary times, and so we are feeling very fortunate to get to chat with you all today and to take your questions at the end of this presentation. All right, so there's a common clinical adage that you've met one person with autism and you've met one person with autism. And the reason that's a common saying is because every person with an autism spectrum disorder can look very different. And part of that is because there are a variety of other psychiatric and medical conditions that often co-occur with autism. And as you can see from the visual here, it's a wide variety. Right? These can be differences in cognitive ability, language ability, differences in behavior, attention, mood, anxiety, as well as medical concerns around sleep or seizure activity, all of which inform how someone presents, how they develop, and how they behave. And so what we're going to be talking about today specifically is mood and anxiety, those two yellow circles. But what we see here is that 70% of children with autism have at least one additional diagnosis by adolescents, which is a large percentage. And so when we think and we talk about autism, we really need to think about what are the other co-occurring conditions that are informing how someone is developing, as well as how someone is interacting with their community, with their school, at home. As I mentioned before, we are going to be focusing specifically on mood and mood symptoms related to depression, as well as anxiety and obsessive compulsive disorder. I'm going to be starting out our presentation talking specifically about anxiety and obsessive compulsive disorder, how we think about those in relation to autism, as well as then how we think about supporting individuals that have anxiety and autism, how we think about treatment, and how we think about specifically parent strategies that can be used to help support and optimize a child's environment when they're struggling with this particular set of symptoms. So what we know about anxiety and autism is that we see multiple studies continue to confirm that rates of anxiety are actually higher in those with autism than in other groups. And each study has a range in percentage of individuals with autism that meet criteria for an anxiety disorder, but roughly 44 to 55% of children who have a diagnosis of autism also will meet criteria for an anxiety disorder. And what's unique about anxiety in the context of autism is that children with autism often don't display age-typical symptoms of anxiety. So what we might see is we might see behaviors that would be more typical in someone slightly younger. And when we see anxiety symptoms, we're going to not necessarily expect an age-appropriate response to anxiety triggers, but potentially symptoms and behaviors that might be expected of someone a bit younger. So what is anxiety? Anxiety is something that is talked a lot about, particularly in this current climate where there are a lot of stressful and anxiety-provoking things happening in our world right now. When we think about anxiety, we think about it as an excessive fear and worry where there is a perceived imminent or future threat. So it's the perception of a threat, and it's then the body and mind's response to that. So it triggers a need to flee or to escape and to avoid a situation that is stressful and anxiety-producing. We understand that anxiety is impacted by the mind, but it's also something that's directly felt in our bodies. So bodily sensations such as heart racing, stomach ache, sweaty palms, red face, these are all things that actually are the body's way of preparing us for a fight or flight response. So when we think about anxiety, our body prepares us either to fight the thing that's making us anxious or to get out of Dodge and run away. So when we think about these bodily sensations, they actually are triggered, and our body learns to have these sensations in preparation for future anxiety-provoking situations. Anxiety is a response to a perceived danger, and it gets in the way of completing activities at home and at school. So when we start to think about a diagnosis of anxiety, we're thinking about this as something that really does get in the way for an individual to interact at home, at school, in their community in a way that allows them to do all the fun things that they want to do. Obsessive compulsive disorder is a separate diagnosis, and it includes two parts. The first of which is what we term obsessions, which are intrusive thoughts that are disturbing and worrisome to an individual. And then the compulsions are that second piece of an OCD diagnosis, and these are habitual actions that actually reduce the distress that has occurred over an intrusive thought. So it's an action that someone performs in order to reduce the stress they're feeling from this intrusive, worrisome thought. And together, these two, obsessions and compulsions, form a reaction to anxiety that, again, gets in the way of daily life. So an example, an obsessive thought might be, if I touch a doorknob, I will get sick from these germs. And the compulsion would be excessive hand washing and cleaning. And this example is particularly apt in this current climate right now. Actually, generated this prior to things that it feels very applicable these days. So the obsessive thought is something that gets in our minds and is distressing. And so the compulsion of hand washing reduces that stress, right? And in this current climate, that's a very protective thing to happen. However, if it's a situation where it's viewed as essentially it's a false alarm, right? There isn't a danger. That hand washing can get in the way of a child's ability to engage in other things and as they get older as well. Another example would be an obsessive thought where, what if I leave the back door unlocked and someone breaks in and hurts me? So the compulsion would be a repeated checking that the door is locked. Even if it's already been checked, confirm the door is locked, a repetitive checking. So these two pieces form that OCD diagnosis. And I think it's important to point out that anxiety can look different in children and teens in general, and it can look even more different in individuals that have autism. So when we think about anxiety, we think about the classic anxiety that we see in adults, we can see a little more of a withdrawal or avoidance or an actual articulation of the fact that I'm feeling worried or I'm feeling stressed out. But for kids, often their ability to articulate that is limited. So we might see increased anger, difficulty sleeping, actual increased defiance, so having trouble complying with instructions or complying with what's going on. Chandeliering is something when essentially a seemingly calm person can kind of fly off the handle, right? So we might see something like that as a symptom of anxiety in kids and teens. Focus can be impacted, right? Which is difficult to tease apart when a child might have autism as well as ADHD, right? But we can see that lack of focus can also happen with children with anxiety. We have avoidance, over-planning, and negativity, right? So these are all symptoms that we need to, when we're thinking about a child that might have anxiety, we want to be thinking about these symptoms that might not be what we would think as kind of the classic anxiety presentation. So one question that we get a lot from parents coming into our center is this anxiety or is this autism, right? And how do we tease apart the two? And the answer is that it really can be both, right? Autism is a brain-based disorder where it changes development and then it changes how someone behaves to different environmental interactions. So when we think about sensory processing differences that can come along with autism, right, there can be an anxious response that comes from a really unexpected sensory experience. Right? As well as change in routine can be very difficult for people with autism. And so when we think about transitions or unexpected changes in schedule, that can also generate anxiety. So when I say it may be both, that is absolutely true. And as we're thinking about treatment, we're going to think about both of these inform how we go ahead and treat anxiety. But when we start to think, is this an anxiety diagnosis, right? Something that we need to treat specifically as anxiety? There's a couple questions that can be helpful. So you can ask yourself, does my child actively avoid situations at home or school, right? Does there seem to be fearfulness around a particular situation and active avoidance? Another thing, has my child come up with rituals that they have to do or have to have me do in stressful situations? This is actually the rituals and needing to do something a particular way. That is a classic symptom of autism. But when we think about the addition of a stressful situation and these rituals that come on specifically when there's these periods of stress or uncertainty, that may be something that's pointing us more towards thinking about anxiety. Again, in the context of autism, but anxiety above and beyond autism. And lastly, does my child regularly seek reassurance from me that something will or will not happen? A lot of parents that we meet with and work with mention that their child is often asking for a parent to reassure them that everything's going to be okay, or that what the schedule is going to be, or what various things are going to be happening. And some of that can be an anxious response. I think what's important to note here is that when we think about teasing apart anxiety and autism, like I mentioned, we are going to be approaching treatment of anxiety in someone with autism using both diagnoses to inform how we're doing treatment. What we think about in terms of determining treatment is we want to think about a child's language ability and a child's level of cognitive functioning, and that's going to inform the kinds of treatments that we recommend to treat both autism symptoms and anxiety symptoms. Now today, our mood and anxiety program at the Autism Center, we do therapy that is targeted more towards individuals with average to above average cognitive ability and language ability. We have a biobehavioral program in the Autism Center that addresses challenging behaviors and potential anxiety symptoms in individuals that are lower functioning in terms of their cognitive ability or have limited language capabilities. So I'll be focusing particularly on treatments for individuals with average to above average IQ, cognitive functioning, as well as intact fluent language abilities. Some of the common sources of anxiety, there's quite a list here, but these are some of the things we often see in our clinic. So there can be separation anxiety, anxiety for germs, insects, dogs, medical procedures, often needle phobias are something that we see rather frequently, performance anxiety. So often individuals with autism really benefit from rules and structure in situations. And so performance anxiety can come up when the rules change or when they feel like they haven't abided by the rule perfectly. That can happen. Perfectionism, a fear of natural disasters, bad things happening to loved ones, social interactions can be very anxiety producing in case of anxiety generally, as well as particularly in autism. And rule breaking can also be a common source of anxiety. And when we think about someone with anxiety and autism, there are additional triggers that we think can also elicit an anxiety reaction. So first of which is transitions. Transitioning from something that was preferred to less preferred, or transitioning in a way that going from one activity to the next, one environment to the next, that can create anxiety, the unknown of that, right? Disruptions in routine, even the presence of a substitute teacher one day when there isn't usually one, or an assembly schedule, can elicit a lot of anxiety in someone with autism where that change in routine is very hard. Disruptions in environment. So even things seemingly benign like mom getting a new haircut, right, can actually elicit anxiety because it's a change in the environment and it's different and unexpected. As well as I mentioned previously, unpleasant sensory experiences. So fire drills, toilets flushing, sensory experiences that can be really overwhelming for someone on the spectrum. That can also elicit anxiety when going into a situation where there might be that kind of sensory experience. So going into a bathroom where you know they have the automatic flush toilets, or going into a school and knowing that a fire drill was recently happening. That can elicit an anxiety reaction. We're going to focus specifically on how to think about explaining anxiety to children and really trying to come up with some concrete strategies and information that parents can use for their child that has autism, as well as potentially an anxiety symptoms. So when we think about explaining anxiety to children, we really want to validate that anxiety is normal. Everyone experiences anxiety. Taking tests, public speaking, riding a roller coaster. Anxiety is normal and it's biological. We're supposed to experience anxiety. And anxiety itself is not dangerous. Yes, it feels uncomfortable, but it's temporary. And what I like to tell kids is most people don't even know you're anxious, right? You may having a really significant anxious reaction, but it may not be as evident to people as you think it might. But we want to go ahead and let them know that yes, it's your body's reaction to something that you're afraid of, but the anxiety itself is not dangerous. Especially when it comes to the physical sensations that come with it, like heart racing or stomach hurting. Often kids can get pretty worried about those physical sensations that happen, and we really want to let kids know anxiety is not dangerous. And anxiety is adaptive. It helps us know when to fight, flight, or flee for real danger, right? Our brains are hardwired to respond to something that's dangerous in a way that preserves and saves us, right? Or else we would all walk into oncoming traffic, right? We need that. We need that part of our brain. And I think it's helpful to encourage kids to think about the brain in this way, that the brain is protective, right? It's doing what it needs to do. But that also anxiety can become a problem. And when your body reacts to danger in the absence of real danger, that's where anxiety gets in the way for us. So if we think about a smoke alarm, right, an alarm can protect us when there's an actual fire, but sometimes a smoke alarm is too sensitive and it goes off when there isn't really a fire, right, like burning toast in the toaster. So like a smoke alarm, anxiety is helpful when it works right. But when it goes off, when there's no real danger, then we may want to fix it. And I think this is a really helpful analogy because it also tells kids that there's nothing wrong with me, right? There's nothing wrong with the way my brain's working. But what it's saying is that it's a little oversensitive, right? It's picking up on things that are actually not a real danger. So in terms of treatments for treating anxiety, a strong evidence-based practice for treating anxiety is cognitive behavioral therapy, and I'm going to go into detail about what that means. But CBT, for short, is well established for treating anxiety in individuals with autism that have average to above average cognitive functioning and language abilities. And what CBT addresses, it addresses a variety of things. First, it addresses our physical responses, how our body responds to fear and the arousal that our body has when we're faced with something that's scary. It addresses thoughts, what we say to ourselves that might either increase our anxiety or decrease it. Emotions, how we feel. Are we feeling worried, scared? Are we feeling angry? Are there other emotions that come up even in anxious situations? As well as then behaviors, what we do and our actions that are elicited from a interaction that is eliciting fear. So one of the things we do a lot in CBT is we talk about a CBT triangle. And this triangle is 3 different things: thoughts, feelings, and behavior. And all of them are connected. So I'm going to use the example of kind of an anxiety trigger that could happen for a child. Mom's late coming home from work, right? And so a thought that could come up for a child that's anxious is, what if something bad happened to mom? The feelings that will come up, right? That thought elicits the brain to go, oh, there's a danger. And then the physical feelings that will come up could be stomach ache, headache, heart racing. And the behavior would be repeatedly calling or texting mom. And likely there'd be difficulty separating from mom next time because, again, the brain prepares us for future anxiety-provoking situations. And so when we think about treating anxiety or OCD, is we want to address what are the thoughts that are popping into your mind that are eliciting anxiety? How do we pick up on our physical feelings that tell us we're anxious? How do we then learn to relax our bodies and decrease those physical feelings that are unpleasant? And then how do we modify our behavior to resist doing something that avoids the situation or exacerbates the situation? So in CBT, we're actually addressing all 3 domains over time. So when we think about treatment for youth with ASD, we know that CBT is well established. But there are some key modifications when working with someone with autism that providers need to be aware of and that we find are most effective for optimizing treatment for kids with anxiety, autism that have intact cognitive functioning and language. So first of all, we think about having a larger parental component. Sometimes people think of individual therapy as it's just the child and the therapist. But when someone has autism, we find that it's most helpful for kids and teens to really loop parents into the process. And actually, there's really strong research to support that for any child or teen with anxiety, looping parents in, having parents understand the skills that are being learned and be able to coach their kids in the moment is really successful. So we lean very heavily on including the family in treatment because we only spend 1 hour with your child per week, and you are spending the rest of the time with them. And we want to make sure that you as parents and caregivers have the skills you need to then be able to coach your child to help learn coping strategies for anxiety-producing situations. We also include positive behavior supports within a session, right? And what that means is we're really trying to think about how do we encourage what we want to see in terms of behavior, and then how do we ignore what we don't want to see, right? So we're trying to think about what do we do to really increase and really incentivize kids to be trying these new skills, even though we know they're scary and hard. We want to make skills more concrete and more visual based, right? So we know that a lot of individuals with autism are visual learners, and they benefit a lot from having a visual way of looking at information. So when we're working with children and teens with autism and anxiety, we try to break things down so it's more concrete as well as to provide a visual way for kids to learn. We also like to let families know that we generally expect treatment to last a bit longer. And the reason for that is that repetition of skill learning sometimes needs to occur for a longer period of time for someone with autism, right? As well as often when we're teasing apart anxiety, we're also looking at behaviors and patterns at home and at school and in the community that have become problematic. And so as part of treatment, we're often thinking about how do we also make family interactions and school interactions more effective and more positive. So we expect treatment to last a bit longer. We also have more focus on external reinforcers and rewards. And so what this means is that we are trying to teach kids to try to do something that's counterintuitive to what their brain is telling them. And that's really hard. And the tricky thing about anxiety is that avoiding a situation is very validating to the anxiety. When we see that anxiety happens, right, and our anxiety goes up and then we immediately avoid a situation, it's telling us, oh, we did the right thing, right? Our anxiety immediately goes down. And so we see that anxiety cycles are really reinforcing. In order to break that, we need to have external reinforcers and rewards to really try to shape kids' behaviors to try to resist checking the locks repeatedly on the door, right? And we want to think about rewards, things that are going to be effective and motivating for kids. We also are going to focus more on behavioral strategies and less on cognitive strategies. So we found that research has shown that doing CBT with kids and teens with autism, there is more leaned on modifying behavior. There's going to be some engagement with thoughts, with worry thoughts and helpful thoughts that can counteract worry thoughts. But we're going to lean more on the behavioral aspects, right? Which is really what we call facing your fears, right? Where we're really looking to not avoid a situation that's scary. Other modifications are things around specifically teaching and setting up kids to be successful in generalizing skills. So what we find is that individuals with autism sometimes have trouble generalizing a skill to other settings. So they may really have a skill down at home, but the ability to use that same skill in school is really challenging. And so as part of treatment, we really recommend that providers spend some time both working with the child as well as working with their systems of support, right? With their parents, with their caregivers, with their teachers to really try to create a team that can help a child generalize skills for coping with anxiety. We also find that we need to essentially really focus on helping improve insight into how a person's body might be feeling when they're anxious, as well as connecting that physical sensation of anxiety to the actual labeling of I'm feeling anxious. This is something that can be difficult for children and teens with autism, and we want to go ahead and specifically teach and spend more time on that. The treatment goals that we would also potentially include would be things like adaptive skills and executive functioning skills, things that might also support a child to be able to adapt in certain situations or to be able to organize and plan out what they're going to be doing. Social stories can be really beneficial to integrate. I think Stephanie's going to be talking about social story in a little bit. And also, I like to note that it's really helpful to have ABA therapy on board sometimes. So if an individual is participating in CBT for anxiety and they have an ABA therapist already, sometimes there's great opportunities for collaboration there. And as providers at the Autism Center, we often love to have the chance to collaborate with ABA providers, applied behavioral analysis, a therapist that might be able to help, again, kind of coach those strategies at home for a child. So I'm going to briefly touch on medication management in the context of anxiety. And there is really very strong evidence to support that the use of medication and therapy together can be very beneficial for reducing both mood and anxiety symptoms in patients with autism. Our center provides medication consultation that really focuses on trying to contextualize whatever symptoms might be going on in the context of autism. And I'm only going to lightly touch on medication management here today because we actually have a whole nother Autism 200 talk that was devoted to it. And so I've provided the link here in the presentation, and it can also be found at our Autism Center website if you go to the Autism 200 page. And it's called Perspectives on Psychiatric Treatment of Autism Spectrum Disorder and provides a really excellent overview of medication considerations and kind of the state of the science right now. I'm going to briefly touch on the services that we provide here at the Autism Center, but I also want to emphasize that individual therapy for CBT is found in the community. There are community providers that are doing cognitive behavioral therapy, as well as other therapies that can support and help children with skill building towards facing fears and reducing their anxiety symptoms. But here at the Autism Center, we provide time-limited individual therapy for kids ages 4 to 21. And specifically, we do CBT for anxiety disorders. And in that general umbrella, we're including OCD, as well as other types of anxiety, which each of these anxieties that are listed here, each of these anxiety disorders have to do with the topic or the trigger of anxiety, right? So for generalized anxiety, it means a child that has a lot of different anxieties. Social anxiety, specifically around social situations. We also do CBT for individuals that have experienced trauma. Selective mutism also is a diagnosis that we treat here through individual therapy. Our emphasis in CBT is on exposure techniques. And what exposure is it's not feeding in to the behavior that might avoid the thing that is fearful, right? So thinking about the context of that example of checking the door locks, right? So if the intrusive thought of, oh my gosh, what if the door is unlocked and what if someone comes in? We're actually going to do exposure where a child resists checking the lock repeatedly. And we might start out slow where maybe they're only allowed to check it twice or maybe 3 times. And then over time we scaffold it to, okay, now we're only going to check it twice. Now once, now not at all. So exposure it's called graduated exposure for a reason, because it means that we're actually helping kids face their fears a little bit at a time, steps at a time. The other services that we provide through the Mood and Anxiety Program as well is interventions for individuals that have tics, as well as trichotillomania, which is a diagnosis for individuals that engage in hair pulling, as well as excoriation or skin picking. So within our program, we also provide those services. Behavioral activation for depression, as well as mindfulness-based stress reduction for teens, and Stephanie's going to talk about that in a little bit. One of our groups that we are very, very excited about, and we have really just been very thrilled to be a part of, both Stephanie and I, is our Facing Your Fears group. And we offer that 3 times a year. It's for individuals ages 8 to 14. And lastly, there's a DBT skills parent group that, again, Stephanie's going to be talking about in a little bit. But these are the services that our Mood and Anxiety Program offers. We also do mental health evaluations as well, and this is for individuals where, children or teens where we really don't know exactly what's going on. We think it's something to do with difficulties with mood and anxiety, but not sure what. We can do a mental health evaluation to help clarify that for you and your family. And there's also opportunities for short-term medication management as needed, as I spoke before. I'm going to briefly touch on our Facing Your Fears group and what that means. So the Facing Your Fears group is an evidence-based treatment specifically designed for individuals with anxiety and autism. It's designed for kids 8 to 14 with anxiety, OCD, autism, and average to above average cognitive ability. And the reason for that is that we engage in a lot of group discussion, and there needs to be, an individual needs to have the ability to engage verbally in this process. It's 14 weeks, and we do both a child group and a parent group. And so how this group works is that children and parents spend some time together in the group, working together to identify fears, identify the steps they're going to take to face a fear. And then we also split up the group so that parents can have opportunities to find community with other parents that are struggling with individuals struggling with the challenges that come with children that have autism and anxiety. And then children are also getting a chance to connect and also have great opportunities to practice social skills, and also just a chance to connect with other kids that are dealing with the same challenges that they might be dealing with. And one of the most exciting things of our Facing Your Fears group is that children get to make a movie of the steps to facing their fear. So at the very end, we do a viewing of all the different movies of kids that have designed the steps they take to face their fear of dogs, to face their fear of bugs or the dark, and we get a chance to celebrate that with them. We found that the movie is a very helpful way to create repetition and practice of those things. And I'm going to go ahead and end with parent resources for anxiety. So the link here in this slide takes you to a really wonderful resource that provides some really wonderful resources about how to explain anxiety to children, as well as resources for thinking about how you might approach managing anxiety at home. Helping Your Anxious Child is a book that we highly recommend and is really a step-by-step guide for parents to handle and manage their child's anxiety at home. And then there's a lot of wonderful books out there that can help support kids that have worries and find an age-appropriate way to talk about those things. We also are happy to chat more about resources at the end should you have more questions, but I would highly recommend this particular website to kind of get you started. All right, I'm going to go ahead and turn it over to Stephanie Pickering to chat with us a bit more about mood.
Well, good evening. It's nice to have you guys here along with us in Facebook land. We can't actually see anybody. We are talking to an almost empty auditorium, just so you know. But we are so glad that you've joined us. And I am excited to share with you a little bit about depression in autism. And yes, I'm a psychologist at the Autism Center. I direct the mood and anxiety program there. And so a little bit about depression. So depression at its kind of most basic level is sadness. Sadness kind of throughout the day, most days for at least 2 weeks. And I put up this graphic because I thought it was just kind of a neat way to think about it. But it includes a lot of different things. So there's physical symptoms, things like feeling sick and run down, muscle pains, difficulty sleeping, maybe poor appetite, could also be an increase in appetite, feeling tired. There's also behaviors like withdrawing from others, not getting things done, not doing enjoyable activities, having difficulty concentrating, and for maybe older teens and adults, you might see an increase in things like drugs or alcohol use. Some of the thoughts that come along with depression: nothing good ever happens to me, man, life is not worth living, my future looks bleak, I'm worthless, it's my fault, I'm a failure. And then some of the feelings. These are obviously a huge part of depression, just feeling overwhelmed and unhappy, maybe irritable. That's especially true for children with depression. Feeling frustrated, lacking confidence, and being indecisive. So I added a few things here to think about when you're thinking about how depression might look in a kid who has autism. We have to think about their affect. So affect is basically the emotions that you show on your face. And a lot of times with autism, you have kiddos who have restricted affect. So they're just not showing a full range of emotions. And maybe that's something that they've had their whole life. Like that's just kind of them. And so with depression, you may or may not see that change to like a sad affect. May always just kind of look the same as it did before. Adaptive challenges have always been an issue with autism. This means things like self-care, wanting to wash their hair or get ready, things like that. Sometimes kiddos with autism are just not as motivated to do that. And so you have to keep that in mind as well. Like maybe you're not seeing a downturn in the adaptive skills. They're kind of the same as they were before. Withdrawal is a similar issue, right? A lot of kiddos with autism maybe just don't have as much social motivation as other people, and so maybe that you don't see the downturn in their, you don't see a change in their withdrawal symptoms. And then physical symptoms, as we know, a lot of kiddos with ASD have always struggled with sleep, or maybe they're picky eaters. And so these are just things that I keep in mind whenever I'm diagnosing depression in somebody who has autism, but you're definitely going to see a change of some sort. And a lot of times I rely on parents to understand how were they functioning before and how are they doing now, and you're definitely going to see that sadness. So let's talk a little bit about depression and autism. So individuals with ASD are 4 times more likely to experience depression in their lifetime. That's a lot more than their peers. It's because their autism diagnosis puts them at risk for things that put us at risk for depression, like social isolation, bullying, having relationship issues, maybe employment difficulties, and then problems in general, just adapting to the demands of a social world. So depression and autism may be associated with some severe consequences as well, maybe a regression in their level of functioning, like their ability to do things the way that they did before, and attempted suicide. So suicide rates in teens in general over the last 10 to 20 years have increased, and this is true for autism. And one recent study by Kirby in 2019 showed that young people with ASD had double the risk of suicide compared to their peers. So obviously something that we're very concerned about in the work that we do. So what to do if you think your child is depressed? Number one, be aware of their symptoms. All the things that I just went through, pay attention. Eating, sleeping, changes in behavior, how they're spending their time, and then just talk to them about it. Tell them that you've noticed and just ask. You can empathize even if you don't fully understand. Sometimes if we find out that our kiddo is feeling really sad, we might think, oh gosh, there's so many things that are going well for you. So you want to let them know that you care, that you noticed, and that this is something that you really empathize with, even if you fully don't understand. Ask about suicide. So it doesn't increase their chances if you just ask about it. You don't plant a seed. You need to ask in a matter-of-fact, non-judgmental way, and then see your pediatrician. Your pediatrician can make sure there isn't a physical reason for their downturn in mood, and seek mental health treatment. And this can start with a referral from your pediatrician to a specialist. I also included a bunch of suicide prevention stuff here. So a suicide prevention hotline, Teen Link, which is a great resource for people to talk to, for teens to talk to other teens. The crisis text line, they can text START to 741-741 24 hours a day. There's a really nice video on the children's website about suicide prevention, what parents need to know. And I always tell my patients, no matter what, if you feel like there's a life-threatening emergency in your house, you can always call 911. That is what it's there for. So how do we treat depression in ASD? Well, Rachel kind of covered some of cognitive behavioral therapy with us earlier. This is what we do. This is actually the most widely used therapy for treating depression in ASD, and it's adapted for people with ASD in the same way that Dr. Earl was talking about it earlier. But cognitive behavioral therapy, we see the cognitive triad here: thoughts, emotions, behaviors. You're going to maybe identify some of the self-defeating thoughts that people with depression might have, like all or nothing thinking, automatic negative thinking, or personalization, which is where you kind of take things personally even though you don't need to. And then we learn to control and change those thoughts, those emotions, and the behaviors that go along with it, and practice more accurate self-talk. And additionally, psychiatric medications are huge in this process too. But something that I really want to emphasize tonight is another type of therapy that I personally just think is so important and so cool, and something that I often talk to families and colleagues about. This is third wave therapies. So they are essentially an evolution and extension of CBT, where you emphasize non-judgmental awareness of thoughts and emotions to do things like decrease avoidance of emotion-triggering situations and increase effective coping. These types of therapies integrate concepts like acceptance and mindfulness and metacognition, so kind of thinking about your thinking, personal values, and spirituality even might be integrated into more traditional behavioral therapies. So why are they called third wave therapies? I thought I'd just do something really quick on this. So the first wave is not Freud. We actually think of the first wave in the 1950s of behaviorism. So those are people like Pavlov and B.F. Skinner, who were really thinking about how humans learn. So this was like classical conditioning and operant conditioning. And then the second wave came along in the 1960s with cognitive therapy and cognitive behavioral therapy, identifying and changing thoughts and beliefs to help people function better. And then the third wave came around in the 80s and the 90s, where there's a little bit more focus on things like context and process and kind of how a person relates to internal and external experiences. So simply put, it means we change our relationship to our thoughts and emotions rather than modify the content of those cognitions. So some examples of third wave therapies, this is not comprehensive, but here's a few of them. Mindfulness-based stress reduction and mindfulness-based cognitive therapy. This is from Kabat-Zinn, kind of in the late 70s, early 80s. This is really promoting kind of awareness of our thoughts, our feelings, and sensations in the current moment without judging them as much as possible. This came out of a lot of pain management work where they were starting to realize that maybe we can't change the pain, but we can change the way that we relate to the pain or the way we think about the pain, and that became a really effective intervention. So that's mindfulness-based stress reduction. Then came along Dialectical Behavior Therapy with Marsha Linehan right here at the University of Washington in the late 1980s. Dialectical behavior therapy is a complex therapy, but at its core, it's teaching people to live in the moment with mindfulness, cope healthily with stress, regulate their emotions, and improve relationships with others. And then acceptance and commitment therapy with Stephen Hayes in around the 80s as well, modifies how a person relates to and responds to internal experiences like thoughts, sensations, emotions, and urges in order to more fully engage in values-based behavior. So research has shown that these types of therapies, these third-wave therapies, can be really effective in things like treating depression or anxiety or pain management, emotion regulation, and even suicide, self-harm tendencies. And so the questions started to become, well, can we use these therapies effectively with people who have autism spectrum disorder? So to answer that question, I'm going to throw it back to 2011, a study that was called the Meditation on the Soles of the Feet. In this study, they were actually working with 3 adolescents who had aggression and autism, and they taught them to rapidly shift the focus of their attention from something that made them upset to a neutral place on their body. So interestingly, these families had already received both psychotropic medications and behavioral training for this aggression, but the parents were still unable to manage their aggression. So the kids were engaging in things like hitting, kicking, and biting family members. Mothers were taught the procedure first, and that happened because they were finding that with mindfulness, you could see improvement in children's behavior if you just taught the parents and didn't do anything directly with the kids. So they used that in this study. They taught the moms first, but then they went ahead and had the moms teach the adolescent, and they had them practice at least twice per day, first with the parent and then with via audio tape, which is another thing that when we're teaching mindfulness to our patients, we always say do it multiple times a day. If you're doing deep breathing or meditation, whatever it is you're doing, you have to practice because you have to build that mindfulness muscle so that you can use it in the moments when you really need to. All right, so I can't give a talk on mindfulness without actually having you engage in a little mindfulness. So we're going to actually do the meditation that they did in this study, and then we'll talk about their results. But please join me in this. If you're standing, you can stand in a natural rather than an aggressive posture with the soles of your feet flat on the floor. If you're sitting, go ahead and sit comfortably with the soles of your feet flat on the floor. Breathe naturally and do nothing. Cast your mind back to an incident that made you very angry, and I want you to just stay with the anger. You are feeling very angry, and angry thoughts are flowing through your mind, and just let them flow naturally without restriction. Stay with the anger. Your body may even show signs of anger like rapid breathing or clenched fists. And now I want you to shift all of your attention fully to the soles of your feet. Slowly move your toes. Feel your shoes covering your feet. Feel the texture of your socks and the curve of your arc and the heels of your feet against the back of your shoes. If you do not have shoes on, feel the floor or carpet with the soles of your feet. Keep breathing naturally and focus on the soles of your feet until you feel calm. Practice this mindfulness exercise until you can use it wherever you are and whenever an incident occurs that may otherwise lead to you being verbally or physically aggressive. And remember that once you are calm, you can walk away from the incident or situation with a smile on your face because you controlled your anger. Alternatively, if you need to, you can respond to the incident or situation with a calm and clear mind without verbal threats or physical aggression. So that's the end of it. But let's see how these 3 adolescents did with this mindfulness technique. So this is called a multiple baseline design across participants. The top is Mike, the middle is Chris, and the bottom is Steve. And they're actually measuring aggression, incidence of aggression. That's what you see in the dots there. And then over time across on the bottom. And so the results of this study are actually really beautiful. They show that the incidence of aggression during pre-treatment were an average of 14 to 20 per week. And then they dropped to 4 to 6 per week during the mindfulness training. And then they went to 0 during the last 4 weeks of intervention. And then what's even cooler is that aggression occurred at a rate of about 1 incident per year during a 3-year follow-up. So for these kiddos, this mindfulness training was very effective at controlling their aggressive tendencies. And so the authors, of course, concluded that adolescents with autism can learn and effectively use a mindfulness-based procedure to self-manage their physical aggression, and these results can last over years, which is great. So since then, there has been additional research. So more controlled trials with both adults and teens who have autism, trying third wave therapies. And these are basically some of the results, and they're very encouraging. So reduction in depression, anxiety, rumination, and increased positive affect, reduced ASD symptoms, so some of the things that we think of as classically autism also have been shown to improve some, and increased social approach, reduced stress, reduced hyperactivity and overall psychological distress, and as they follow these kiddos over time, for these studies, they showed that this lasted 2 months later. It's very exciting. So some of the modifications that are used for kiddos with autism include shortening the activities in meditation. Some of the meditations for mindfulness-based stress reduction are very long, so they shorten them. Simplify the language a little bit. Reduce abstractions like taking away metaphors, reducing cognitive reappraisal where you're asking people to think about their thinking and think about ways they could change it, and then including the use of visual aids. I will say I've led some mindfulness-based stress reduction groups for teens at Seattle Children's Autism Center and found that these modifications do indeed help quite a bit. So there's another group of people that I want to talk about tonight when we're thinking about mindfulness, and that is parents. I joke that this is an actual picture of me after homeschooling my kids for the last week and a half. Not an easy time to be a parent right now, but also, just parenting in general is hard. And this list here is just a list of some of the things that parents do on a daily basis, like accommodating, modifying the environment, providing structure, routine, and occupation, supervising and monitoring, managing noncompliance, responding to problem behaviors, managing distress, maintaining safety, and analyzing and planning. So it's quite a mouthful, and it means we're just busy. We're constantly thinking about our kids and how to help them. And this study that I found was finding that looking at parents of kiddos with autism and their parenting behaviors, they found that they were doing quantitatively greater and qualitatively more complex parenting. And so, naturally, we started to ask ourselves, how can caregivers also benefit from mindfulness? And so far, there's some nice research. We'd love to see more of it, but there's some nice research studies out there that show really nice things like significant gains in subjective well-being, reduced parenting stress, depression and anxiety, and improved general health, reduced depression, anxiety, stress, and marital conflicts, and improved emotion regulation, like increased positive reevaluation and lower blaming of self and others, all as a part of learning mindfulness. So very encouraging. I want to talk for a chunk of my time tonight about dialectical behavior therapy. And the reason I'm focusing on this is, ironically, it's the one where there's less research out there about effectiveness of DBT with ASD. However, from my own experience, anecdotally, I can tell you that there's a lot of kiddos who get this treatment, particularly if they end up in inpatient or residential treatments, because that's where they're doing a lot of DBT work. So I want to talk about the therapy a little bit, and then I want to talk about why I think it is something that we should start pursuing even more so for our kiddos with ASD. So DBT was developed for patients with emotion dysregulation and suicidal self-harm tendencies. The idea of a dialectic, I think, is very cool and one that I use often in my own life. But it's this idea that there's two opposing statements can both be true at the same time. So it is true that everyone is doing the best they can, and also people need to do better, try harder, and be more motivated to change. So the primary dialectic in DBT is this. It's the dialectic between accepting people exactly as they are and knowing that they need to change. So DBT uses this kind of dialectical thinking to help people move through emotion dysregulation and conflict towards stability and living a life worth living, building a life worth living. So a little bit about the acceptance strategies here on the left-hand side. The first is mindfulness. Yes, so we've been talking about mindfulness, using skills like observing, describing, participating fully, while at the same time being non-judgmental, one-mindful, and just choosing to do what's effective. Mindfulness is kind of that thing that allows you to build a little bit of space between your experience and your reaction to your experience. So it helps you to make more wise-minded decisions. Distress tolerance, this is managing a crisis without making it worse, and also at times accepting reality as it is. So it includes a whole bunch of really nice skills like self-soothing, scientific ways to calm the body, making meaning, and sometimes just radically accepting where things are. On the change side, we use things like emotion regulation strategies, maybe just understanding and reducing vulnerability to emotions, and then learning to change them. And then also interpersonal effectiveness skills, so getting your needs met, maintaining relationships, while also maintaining your self-respect. So some pretty amazing skills, and they're given through 4 main modalities, so individual therapy, skills building class where you learn all these skills together with other people in DBT, phone coaching in between your sessions, and then consultation group for therapists to help make sure therapists are doing the best job they can and also get support for themselves. DBT may also include things like medication management and other necessary treatments like treating anxiety or trauma with exposure as well. So DBT and ASD, what we know. So in the review of literature and published studies that I was able to take a look at, there isn't a whole lot. I did find a book chapter. I did find a dissertation that came out of Hofstra University where they were teaching adolescents the emotion regulation skills and the interpersonal effectiveness skills particularly, and they did find that these were really helpful for teens. And then there's a bunch of research on emotion regulation skills and ASD that has been showing good positive effects. However, I just want to point out some of the things that we already know about our kiddos with ASD. As somebody who's worked in the ASD community for a really long time, we kind of know what works, and then now I've been seeking out this DBT training and finding that there's just a lot that matches here. First, it's an intensive therapy. There's more hours per week, and it's longer, and as Rachel said earlier tonight, that's something that we just expect for our therapy with children with ASD. It's highly structured. Marcia Linehan, who developed DBT, her answer to kind of the chaos of emotion dysregulation was to bring structure to it. And children with autism often benefit from structure and predictability. It's also filled with a ton of good concrete coping skills like emotion regulation skills, distress tolerance skills, really specific things you can do to calm your body down when things are hard, interpersonal effectiveness skills. They even come with scripts that people can learn to figure out how to ask for what they want or say no to something. And the scripts are something that we use a lot for kiddos with ASD. There's a strong base of mindfulness that is actually kind of the foundation of DBT is mindfulness, and as I pointed out earlier tonight, that's something that we find is effective for kiddos with ASD. There's a lot of support between sessions, so they can reach out to their therapist and say, I'm really struggling here. Can you help me? And one thing we know about autism is that they really benefit from things like that, where you can do in vivo coaching to help them learn new skills. There's also really significant support for both parents and therapists, which I think is really important too. So currently at our center, we are not offering a full DBT program. I do have dreams that maybe that will happen someday. But the one thing that we are offering is something called the Parenting Teens with Strong Emotions group. This was compiled by my colleague here at Main Campus, Kirill Gernenvetko, and really is a combination of both dialectical behavior therapy, so everything I was just describing, along with parent management training, so a real behavioral intervention. So some of the things that we cover include monitoring and crisis management, validation and relationship building, like having positive time with your teen. Dialectics, that was what I was just describing, so kind of finding the middle path when you're in conflict. Huge part of it is mindfulness. We talk about emotion regulation, distress tolerance, and then the rest of them here are really behavioral incentives and privileges, attention and ignoring, having good house rules, clear instructions, behavioral contracts, as well as limit setting and effective consequences at home. So we basically have used this curriculum now with 2 groups at our center. We haven't changed it that much from its original form, which was for typically developing teens and their parents. What we do is myself and Dr. Savasco, who I lead this group with, are experts in ASD, and so we're able to just kind of integrate our knowledge about ASD into our discussions with parents. So as I said, we've run it a couple times, and I thought I would share with you just some of the parents' reactions to it. This is a satisfaction survey that we gave them. And basically, they're saying, and this is a Likert scale from 1, which was not helpful, to 5, which was very helpful. And they are basically saying, parents are saying these are really useful skills for us. They feel more confident in their parenting of their teen. They saw improved behavior in their teen, which is huge, because again, we're not doing anything directly with the teen in this group. They're continuing to use their skills, and overall, they're satisfied with group. It's a 4.5-star rating on Amazon, so very exciting for us. But even more important, these are some of the quotes from parents about saying what was helpful about the group. So concrete skills to handle various areas of challenging behaviors, hearing and sharing with other parents in similar situations, and practicing mindfulness, meeting with others and sharing similarities and solutions. The dialectics, mindfulness, and acceptance were most helpful. The mindfulness skills were a revelation, and just overall having a feeling of belonging. I will say I've been in conversations with parents who've done this group and also who are currently in the group, and talking with them over the last week or so with everything that's been going on and having their teens home all the time in such intense time, and had a parent yesterday just saying, I'm so grateful that I have these skills, because they've been using a ton of validation and dialectic thinking and mindfulness for themselves as well. So really glad to hear that. So I thought I would put up also some resources around mindfulness and third wave therapies. The Parenting a Teen Who Has Intense Emotions book is actually one of the main sources that was used to develop the Parenting Teens with Strong Emotions group. So I highly recommend that if that sounded interesting to you. There's also books on parenting your anxious child with mindfulness and acceptance. There's a number of workbooks I put up here for stress reduction. That's a MBSR book. Don't Let Emotions Run Your Life. That's more a DBT-oriented book. The Whole Brain Child is very third wave therapy-like for parenting. And then another workbook called Beyond the Blues for depression. I will also recommend a number of apps. I think this is just a really great way to bring mindfulness into your life if you're interested in it. These are apps that I have used and recommend. I like Insight Timer personally. I use that quite a bit, but lots of people love Headspace and Calm. Virtual Hope Box was actually developed by the federal government for use with veterans, and so it's totally free, and it has some really nice things in there like progressive muscle relaxation, and a number of things that could be helpful. 10% Happier is another example of a great mindfulness app. And then there's the Center for Child and Family Wellbeing at the University of Washington. They have a lot of nice online resources for mindfulness, and they also have, and mindful parenting, and then they also have classes that you can take, and I've taken some of those classes, and they're really great. So another resource. I should mention that unfortunately for me, I am not connected in any way to any of these resources financially, so you should know that. Okay, so we didn't think that we could do a talk tonight on mood and anxiety without directly addressing the anxiety that's going around about the coronavirus. We know that we are all in just a very somewhat tense time, and so we thought we would share some tips as people who treat anxiety on a regular basis. So for your kids, we just recommend most of all that you listen to them and that you're present. Your presence is likely one of the most comforting things for your child. And so when you're with them, try to give them your full attention at times. Listen to how they are feeling and listen to any questions that they have. You want to provide reassurance and helpful thoughts in general. You could say things like, "This won't last forever. Everyone is working together. We are fighting this virus by washing our hands and staying home." So some simple phrases that you could teach them that are really helpful thoughts for all of us. Checking the facts is something we always teach families to do when kids are struggling with anxiety. I actually had one of my patients last week say to me, "Everyone is going to get this virus and die except for me," right? So that was that child's worried thought. And we could do a little checking the facts on that. No, actually, most people are going to be okay. Maybe your child is fearful of getting it themselves, so you could say something like, "Well, actually, this virus hasn't been that bad for kids." In general, for sure, be honest. Don't make things up. And of course, if they ask hard questions, you can be honest. Like if they ask if people will die, you can say, "Yes, some people will die." But also, don't catastrophize it. You want it to be something that they can understand, especially for kiddos who have autism. You want to make sure you're using that age-appropriate language, and if possible, maybe be a gatekeeper for all of the information that they're exposed to. With these discussions, you kind of want to keep them a little brief and factual and then move on, shift to something different. You want to give your kids a sense of control. All of the hand washing tips, so great. 20 seconds, help them sing a song while they're doing it, teaching them to cover their coughs, teaching them that staying home is a piece of that. And you could even practice deep breathing together. We've been doing this at my house, doing a quick 4 counts in, hold it for 2 counts, 6 counts out. Can be a really nice way. We say, you're sending a message from your body to your brain to say that you're safe and okay. The next thing is to have a schedule or a routine, keeping some predictability in their day. Keep your bedtimes and your meal times, and if you're schooling from home, hey, just come up with a really simple but consistent schedule as much as possible. If you have ABA or other therapies that you usually see, check with your provider about doing remote check-ins either via phone or via telemedicine. I know a lot of patients that I work with are doing that now. So another good option to kind of keep some consistency for your kiddo. Plan fun and relaxing activities. This is important for everyone in the family, not just the kids. Bake, garden, play outside, maybe try a video game with your kid. If your kid has some really restricted interests, maybe it's time to dive into those with your kid and just say, "Hey, teach me how to play this," or maybe watch them and say, "I love how you're doing that." So look for ways to work in fun and relaxing activities for everyone. For parents, definitely we encourage people to be a positive coping model. And what I mean by that is you can acknowledge your worries to your child and then show and demonstrate how you cope with them. So something like, "I'm feeling a little bit worried, but I know that my worried feelings aren't going to last forever. I'm going to take a deep breath and I'm going to focus on making cookies," or find some other enjoyable activity, whatever that is for you, but kind of demonstrate to them that you experience this emotion and then how you cope with the emotion. I've also included a couple of links here. There's a nice article that came out from Seattle Children's about helping your children and teens cope with their anxiety about COVID-19. And then I also included this social story by Carol Gray, which is awesome. If you guys can click on it and download it. It's called Pandemics and the Coronavirus. So a really nice example of a good social story. I also have some tips for parents. Just practice good self-care. Make sure you're getting adequate sleep, nutrition, and exercise. Use mindfulness. Pause multiple times a day and just observe your thoughts, your emotions, and your bodily sensations. A part of mindfulness is being aware of how you spend your time. So if you find yourself spending all your time reading scary news, right, getting yourself anxious, be mindful of that and shift. Try relaxing. Maybe try out one of the mindfulness apps that I was talking about. Practice, again, just shifting your attention. You could shift to happy things. You could think about things you're grateful for in your family or in the world right now, all the medical professionals that are helping out. Just this act of staying home, which is such an amazing thing that we're all able to do together. Or you could shift to something like the soles of your feet, which we practiced earlier tonight. You can take a self-compassion break. This is somewhat stating something that feels really obvious, but doing it with compassion towards yourself, like I am struggling. It is difficult to deal with a pandemic. I am not alone. Everyone is facing this, or I am doing the best I can. Be sure that you're talking to other adults and just connecting with other people to get support. Obviously, not many of us can do that in person at this point, but texting, calling, using social media or FaceTime, remembering that social distancing doesn't mean that you're isolating yourself. And I will end with this. This has been something that's going around in kind of the mindfulness circles that I'm a part of that I thought I would share, that you can do a quick loving kindness meditation while washing your hands. It takes about 20 seconds. To do loving kindness, you can, feel just sense the water and the soap on your hands, the touch of your hands and fingers, and with a lot of compassion, just thinking about yourself, you can say, may I be happy, may I be safe, may I be healthy, peaceful, and strong. And then extending that to everyone around you. May everyone be happy. May everyone be safe. May everyone be healthy, peaceful, and strong. And I think we'll take questions. Do you have questions for us or no? Okay.
So the first question we have is from Meredith Robinson. She asked for the third wave therapy study you shared.
Yeah.
Were the kids in that study high functioning?
In general, so it was interesting. I actually read the full study, and I was looking for more descriptors, and they were a little bit vague about it. They said that they lived at home with their parents and that they attended local schools, but you can tell by the language that was used in the mindfulness exercise that, yes, they had relatively good verbal skills and cognitive skills. Yeah.
Thank you. So the next question we have is from Madison Ashton. Say you're assessing a child to determine their course of treatment. The child has anxiety and has difficulty reading social cues, nonverbal and verbal. When communicating with peers, in your assessment, how do you parse apart whether the child is having difficulty processing social cues due to their anxiety versus due to social language challenges?
Want to take that one? Yeah.
All right, that's a great question. So I think that this is often a very common question of how we tease apart what is social anxiety and what is social communication challenges that are related to autism. So in an assessment arena, when we're thinking about that, we really want to understand, when did these difficulties with understanding verbal and nonverbal cues, when did they start? Because when we think about autism, we expect that early on in development, kids were showing difficulties with social communication in general. And that means both the kind of communication of various verbal and nonverbal information, as well as interpreting it from others. So that's something that when I'm assessing to tease apart things, I want to think about, right? When did this happen? When did you first start noticing that your child was having difficulty understanding those cues? Often that difficulty understanding the cues is more akin to what we think about symptoms related to autism, whereas social anxiety, often individuals with just social anxiety and without autism, they are savvy with social information, they understand social cues, but there's an anxiety reaction that happens in the midst of social situations that causes them to avoid. Now, autism and social anxiety can co-occur. So say a child has always had difficulty with verbal and nonverbal cues and understanding that, and that leads to a lot of miscommunication and potentially conflict. And so over time, there's an anxiety reaction that's elicited from social interaction because it's often fraught with a lot of challenges and difficulties. So when we're thinking about an assessment, right, sometimes we might say, oh, this is more autism related. When there still is that anxious response, it might prompt us to say, okay, there's a bit of some social anxiety as well as autism.
All right, we still have time for questions, so if everyone can just leave those questions in the comments for us, we will ask them on your behalf.
Yeah, we're trying to social distance here.
All right, so this question is from Aria Winters. I was diagnosed with Asperger's when I was 13. Is it true this is now just part of the autism spectrum and Asperger's doesn't exist? And how do people with autism deal with people thinking less of them for having autism? For example, people associating being retarded with being autism. If this isn't an okay question, feel free not to answer the second part.
That is a really wonderful question, and I very much appreciate it being asked. I think this is, there's a couple different parts to that question, and I'll try to answer it as best I can, but I also want to validate that that's an experience that a lot of people with autism feel, right? They may feel judgment for the way their brain working a little bit differently from other people. So in question about Asperger's, that is a great question and something that's very confusing. So to try to clarify a bit, so in 2013, there was a change in the type of clinical diagnoses that doctors and psychologists make to say, yes, this is autism, or no, this isn't autism. And previously, there was multiple types of autism when we think about diagnosis, and Asperger's was one of those. And in 2013, after a lot of research that showed us that really clinicians weren't super reliable about deciding when someone had Asperger's versus when they had autistic disorder, or when they had something that was called pervasive developmental disorder, not otherwise specified, which is a mouthful. And we found that those different diagnoses didn't necessarily inform treatment in a meaningful way. So in 2013, the powers that be that decide those clinical diagnoses said, okay, we're actually going to remove those diagnoses from the diagnostic manual, or the DSM, which is what we use when we think about diagnosing autism. And what that meant is that now all three of those separate diagnoses are now under the umbrella of Autism Spectrum Disorder. So what that means is that when someone is getting a diagnosis from 2013 on, and they would receive a diagnosis of autism spectrum disorder, whereas previously they might have received a diagnosis of Asperger's, for example. If they didn't have language delay early on, that would be the diagnosis that would be appropriate. So from a clinical standpoint, when we're in a clinic and when we're diagnosing autism, that's the case. But I think it's really important to note that that does not mean that Asperger's is not a very important identity marker for individuals with Asperger's. And we find that in the community of individuals with autism, that is a really important part of their identity. And so while it's not a diagnosis that we give now, we fully acknowledge that that is a really important aspect of identity, and it is absolutely okay to identify as having Asperger's and using that to identify other people that might have Asperger's as well, to engage in that community. It can be confusing when we hear those differences in terms of the medical terminology, but in the community, you'll find that lots of people identify as having Asperger's, and we as clinicians have no intention of taking that away. We understand that's a really important piece. And I think just as a follow-up to the second part of the question, I am just so sorry that experience happens of feeling judged or feeling stereotyped, right, based on diagnosis. There's a lot of misinformation out there about autism, and I like to think that things are getting better. I like to think that we're really trying to educate community members about what autism is and to really help impress on people that autism is a spectrum, right? That there are some individuals that have intellectual disability, that have difficulty with cognitive functioning, and they have autism, but there's also individuals that have completely intact cognitive abilities, and they also have autism. So we really want to respect the diversity that is autism, and that's something that we as providers and that I know the community in general is really trying to educate people so that there's less mistyping and stereotyping and less misinformation that ends up being hurtful to people. Yeah.
So the next question we have is from Mandrake. How do you help an autistic child with limited expressive language but average to high IQ with anxiety and panic attacks?
That is a really excellent question. So I think sometimes we lean very heavily on language and on someone's ability to articulate how they're feeling and what that experience is. And yet we really, especially here, at the Autism Center where kind of autism is really the primary area of focus for our clinical practice, is we really want to understand that there are a lot of things that communicate what's going on, right? And we while the world tends to put a lot of emphasis on language, we also know that behaviors communicate things. And so I would say that when you're noticing anxiety and panic attacks and wanting to address that can still be addressed in treatment. Now, it's possible that cognitive behavioral therapy might be modified, right? Where maybe we lean less heavily on the ability to articulate what's going on, and instead we rely more on visuals, right? Providing more choices, opportunities to write or draw how they might be experienced. And those modifications can definitely be helpful and can still help support someone with these particular challenges and help mitigate symptoms. The other thing is really looping parents in, right? Parents, you know your kids so well that your ability to help them and to learn the skills yourselves and help your child practice them can be really helpful. So we can still very much lean on behavioral skills and the behavioral components of CBT to help support that. I would just also say that we like to partner with applied behavioral analysis for kids that have limited language abilities, because ABA is a very behavioral approach. It's approach to, it can still be teaching coping skills and practicing and doing these things, but it's coming at it from a more behavioral standpoint that wouldn't be as reliant on language in that way. Yeah.
One more follow-up question. So if a child has panic attacks and anxiety directly related to specific learning disabilities, how do you help them through if it's legitimately difficult to the point of panic and they have to continue with school every day?
Yeah, that is a really excellent question. I know we work with a lot of patients that school is a major anxiety trigger. There are a lot of things that are happening at school, a lot of demands being placed, and especially when learning difficulties are also in the mix, it can be so difficult to have to day in and day out confront those difficulties. So, I would really recommend, it seems like this could be a situation that it could be really helpful to go and talk with your doctor, who potentially could give a referral to opportunity to talk with a therapist and start to kind of troubleshoot what that might look like, right? Often we see patterns of school avoidance that can come up with kids that repeatedly have stressful circumstances at school, and they may want to avoid school. And we as therapists are often working with patients to try to resist that avoidance cycle so that they can still engage. Because school is one of those things where it can be so stressful, and it's one of those things that in life it really provides good instruction for then when we need to go on and think about future employment and engaging in a community, right? And so these are valuable skills to learn. I think, from based on what this listener is saying, I think it would be really great to get a chance to speak with your pediatrician, who might be able to make a referral or direct you to someone who could talk more about the specifics of that. But I think that there would definitely be treatment opportunities to help address those challenges.
And that is the last of our questions tonight. Do you guys have any last words for them?
Thank you all for tuning in. We very much appreciate the opportunity to chat with you tonight.